We can get started. I'm going to introduce Dr. Daniel Press. He is the chief of the Cognitive Neurology Unit and also the clinical director of the Berenson Allen Center for Non-Invasive Brain Stimulation at the IDMC. He's an associate professor of neurology at Harvard Medical School and is a leader in education, research, and clinical treatment with a focus on diseases like Alzheimer's and Parkinson's. His research concentrates on studying the effects of brain disease on one's ability to learn new motor skills and how those effects can be reversed. With that being said, I'm going to turn it over to Dr. Dan Press, who can begin his lecture.
Excellent. Thank you so much, Jackie and Hannah. And thank you everyone for tuning in on a Saturday morning. I see a lot of familiar names in the list of participants and also some new names. So it's really great to be able to talk to you about something that's of clear interest, I think, to all of us. Please feel free to ask questions along the way. I think it'll make it more interactive. I can't see you, so it'll make me remind me that you're out there if you ask some questions along the way, and we'll get started. So let me start sharing my screen. Give me just about 2 seconds to get this set up. So I'm going to be talking about the cognitive aspects of Parkinson's disease, what we know about what causes them, what can be done, hopefully, to prevent them and to treat them when they arise. Here are some of the disclosures. We always tell people what kind of research we're doing. None of the research I'm doing directly involves today's talk, but we do studies funded by the NIH, as well as research studies mainly on Alzheimer's disease. So I want to talk a little bit, maybe to get us started, to try to fit Parkinson's disease into the larger field of all the neurodegenerative conditions, including Alzheimer's and others. And we'll talk about where Parkinson's fits in that world. Then we'll talk about how Parkinson's affects cognition, what can be done to prevent those effects, what treatments are available, and I'll also talk a little bit about the relationship between Parkinson's disease and depression, because depression can also affect cognition. So the first thing I want to start by saying is over the last 10 or 15, maybe even 20 years now, through a series of small discoveries, we've largely established that essentially all the neurodegenerative conditions, from Alzheimer's and Parkinson's disease to rarer conditions like frontotemporal dementia, and even very rare conditions like Yaakov-Creutzfeldt or mad cow disease, essentially all these diseases are due to proteins misfolding and building up in the brain. So if proteins misfold and build up in the brain as we age, the first question might be, why do we get these conditions? Why can't we get better at clearing out these proteins so that we never develop any of these disorders? And the reason, I think, is really shown on this slide really elegantly. So this is how long the human life expectancy has been through human history. So back in the Bronze Age, the average lifespan was only about 18 or 20. Similarly, in classical Greece, it was only about 20 to 30. But really, there's very little change over the next, millennia. But even in early 20th century, that's 1900, the average lifespan was only about 30 to 40. Even if you account for women who died in childbirth and infant mortality, it was unusual for people to live into their 60s or 70s, let alone later than that. So really, there's not been any evolutionary pressure to get better at removing these misfolded proteins. And just in the last 100 years, the current world average lifespan has increased dramatically. And in fact, where it says 67, this is now actually out of date as of this year. It's now up to 72. That's worldwide life expectancy. What this means is, for the first time on our planet, there's more people who are over the age of 65 than there are people under the age of 5. This has never happened before in human history. So really, we're a planet of people who are living much longer, and these misfolded proteins are building up. There's really 3 broad categories of proteins that build up in the brain. One is amyloid, and that builds up primarily in Alzheimer's disease. Another one is tau, and a rare one called TDP-43, and those build up in diseases such as frontotemporal dementia. But tau also builds up in Alzheimer's disease. And then lastly, on the left hand is the synuclein diseases. And these include Parkinson's disease and dementia with Lewy bodies. And synuclein builds up specifically in Lewy bodies. And I'll move my mouse over. These little pink circles are Lewy bodies inside a neuron. This is a pigmented neuron. All the brown stuff is the pigment that tells us that this is a pigmented neuron that makes dopamine. And these Lewy bodies are building up inside there. And what happens is in Parkinson's disease, these pigmented neurons develop these Lewy bodies and die. And so this is the midbrain from someone who died without Parkinson's disease. And you can see this dark substance or substantia nigra is healthy and there. But with someone with Parkinson's disease, those cells die and the substantia nigra becomes less and less dark. It becomes almost pale. Now, these proteins don't just build up in certain parts of the brain, but they actually spread from neuron to neuron. So, for instance, in Alzheimer's disease, amyloid starts building up in certain brain areas, and then over time it spreads. Similarly, tau also builds up in certain regions and starts spreading from those regions, particularly in the hippocampus and the parts of the brain right next to the hippocampus. In synuclein, the protein that builds up in Parkinson's disease, starts all the way down in the brain stem, and then it spreads up the brain stem and eventually out to involve the cortex as well. Now, Parkinson's disease, the hallmarks of it are all motor things like stiffness of movement, slowness of movement, and tremor. But many years before those symptoms come on, there can be what are called prodromal symptoms, or symptoms that come on before the motor symptoms. And some of these include loss of sense of smell. Another one is constipation. And the third one is REM behavior disorder, this interesting disorder where people act out their dreams. Normally during REM sleep, all our muscles are paralyzed except for our eye muscles and our breathing muscles. But people with REM behavior disorder, there's a failure of that paralysis. So instead of being paralyzed, they're still able to move, so people act out their dreams. And these symptoms of things like loss of sense of smell, constipation, REM behavior disorder, they can come on 5, 10, 15, maybe even 20 years before the motor symptoms come on. And we think they're trying to tell us a little bit about how Parkinson's disease starts and how it evolves. And I'll give you an example of that by focusing on constipation. Very exciting topic for a Saturday morning, constipation. So constipation is present in about half of the people, 40% of the people with Parkinson's disease will have had constipation even before they develop motor symptoms. It can precede motor symptoms by 5 to 15 years. Now, constipation is very common. I'm sure many of the people on the call who don't have Parkinson's have had constipation at one point or another. But having regular, consistent problems with constipation does carry a higher risk for developing Parkinson's disease by about 3-fold. And what we know is that the reason why there's constipation is there's slowing of the gut, of the movement through the small and large intestine. And in fact, if you look at colon markers, if you put them in there and you say, how long does it take for the markers to pass through the gut? It takes much longer in people with Parkinson's than people who are healthy controls. Now, this is sort of interesting, but it gets much more interesting when we realize that the way the gut moves things through is through the parasympathetic nervous system. That's a part of the nervous system that innervates the gut in the internal organs. And that parasympathetic nervous system is connected to the brain via a nerve called the vagus nerve. And the vagus nerve lands in the brain stem in what's called the dorsal motor nucleus of the vagus. And if I go back to where Parkinson's disease starts, that is exactly where it starts. This little red area down here is literally the dorsal motor nucleus of the vagus. So one of the intriguing ideas is that maybe what's happening for some people with Parkinson's disease is that years before they develop the motor symptoms, synuclein starts misfolding in the gut. And that synuclein builds up in the neurons and the nerve cells in the parasympathetic chain ganglia of the gut. It then travels up the vagus nerve, lands in the dorsal motor nucleus of the vagus, and then starts spreading through the brain. If this were the case, then that means that people who have had their vagus nerve cut ahead of time would be less likely to develop Parkinson's disease. And indeed, in a large Swedish study, that's exactly what they found, was that people who had had their vagus nerve cut had about half the rate of developing Parkinson's disease as people who did not have their vagus nerve cut. And it only worked if the vagus nerve wasn't cut entirely, not if it was only partially cut. So this is evidence, and there's other evidence as well now, that at least for some people, Parkinson's can start in the gut, in the nervous system of the gut, travel up the vagus nerve, get into the brain stem that way, and then spread. Now, I should say that obviously once someone has Parkinson's disease, cutting the vagus nerve would no longer work. It would only be, something that you would ever even consider before, well before the symptoms. So this is a little bit about where Parkinson's fits in the larger category of neurodegenerative disorders like Alzheimer's and others. It's due to a misfolded protein, but in Parkinson's, we think the protein is synuclein rather than amyloid or tau like in Alzheimer's disease.
Someone asked, why would someone know to cut the vagus nerve?
Yeah, that's a good question. So this is still very much in the theory. I've never heard of anyone actually getting a vagotomy to try to prevent Parkinson's disease. Having said that, if someone, very, very rarely, there are families with Parkinson's who have very strong genes that put people at extremely high risk of developing Parkinson's. And that would probably be the population where a research study could get done to see if cutting the vagus actually lowered the risk of Parkinson's in those very rare families. But other than that, I don't think it really has any clinical application yet.
And the second question, someone said, so if you would cut the vagus nerve prior to symptoms, how do you base the decision to do this procedure? Is it a risk factor along with constipation?
Yeah. I'm always a little bit hesitant to talk about the vagotomy story because it's still in the we're working it out hypothesis field. It's not been tested in the forward direction, what we call prospectively. It's only retrospectively that we've noticed that people who have had vagotomies have a lower risk of developing Parkinson's, but not in the forward direction that actually cutting it actually is beneficial. So I think that it's an area where we need to stay tuned and pay attention to, but I've not heard of anyone, to my knowledge, getting their vagus nerve cut intentionally for this reason. It used to be a surgery to prevent ulcers, as it turns out. That was the main reason why people got the surgery 30 or 40 years ago. Now, to be honest, the surgery is done much less because we have much better treatments for ulcers. You don't need to have a surgery. You can just go on to medicine to treat ulcers. I want to talk now a little bit about what we know about the risk factors for developing memory loss and what can be done about it. Now, there's a large literature about this in terms of dementia in general and Alzheimer's disease. There's less literature that I've been able to find specifically on preventing cognitive symptoms in Parkinson's, but I think a lot of these factors likely overlap, and I'll explain why. But for sure, we know one of the risk factors for developing memory loss in general is age. As we get older, the risk of memory loss doubles for every 5 years that we live to be over the age around 60 or so. But there are preventable risk factors, at least for developing Alzheimer's cognitive impairment, and probably for developing Parkinson's cognitive impairment as well. And these include things like obesity, smoking, high blood pressure, and diabetes. Each of these carries a risk of about 1.5 to 2 times for developing cognitive impairment. There are also some protective factors, like having good cognitive reserve. That means being well educated and staying sharp. And reasonable amounts of alcohol, not too much and not too little, may also be protective. I want to talk a little bit about some of the things that we think can help to prevent memory loss. And the first one I want to start with is diet. And the main kind of diet that we know of for preventing Alzheimer's disease cognitive impairment, and I think there's hope that it would also work for Parkinson's, although I don't think it's been tested directly yet, is a Mediterranean diet. That's a diet that's high in fish and olive oil and nuts and in green leafy vegetables. And as I was just talking about with vagotomies, there's retrospective data. That means data that looks backwards in time and says people who kept that diet had a lower or higher risk of developing memory loss. But the best kind of data is prospective data, where we randomize people so that half of the people are randomized to do one thing and the other half are randomized to do another. And that gives us much more information. And in fact, that kind of information has been done with the Mediterranean diet. In a large PREDIMED study, people were randomized to either stay on their regular diet or go on a Mediterranean diet using lots of extra virgin olive oil, or a Mediterranean diet high in nuts. And you can see in both groups, people were less likely to develop heart attacks, strokes, and they had better cognitive outcomes as well. In the study, as an aside, the way they randomized people is they told people you should go on a Mediterranean diet high in extra virgin olive oil, and they then started sending them like gallons of olive oil to promote that use. And the nuts group got tons of almonds being sent to their house regularly to promote them sticking to the Mediterranean diet. So in terms of diet, the kind of diet we think is most beneficial is the Mediterranean diet.
Okay, we have a couple of questions. The first one is, I understand that reducing sugar and gluten reduces inflammation. Would this help Parkinson's, extending inflammation from gut to brain?
We don't know. We honestly don't know. So I don't think there's any evidence that that's the case. In the way the proteins spread along the nerve, it doesn't require inflammation for that to happen. So I don't think there's any evidence that you need to go on a low gluten diet. I think just the Mediterranean diet would be what I would do if I was in that situation.
Okay, and the other question is, how much wine and which color is preventative? That counters to some things I have read.
Yeah. The short answer is we don't know. For any wine experts or enophiles out there, there's not a lot of difference between red wines and white wines. It just has to do with the way the outer skin of the grape is processed, and they taste about the same. So I don't think we know specifically what kind of wine is best. So I would say I would be careful about not drinking too much. Clearly, like a single glass of wine a day or something like that is totally fine. I would be careful about drinking much more than that. And I guess I'll put a plug in here for Italian wines. They're delicious, but I don't know that there's any reason to prefer one kind over another.
Okay, and a final nutrition question. Should people with PD eliminate or reduce dairy products from their diet?
I don't think they need to, but I do think that, lots of milk fat is bad. So butter and things like that, and high fat cheeses are not part of the Mediterranean diet, but low fat cheeses are. And as long as you don't have lactose intolerance, I think it's more than fine to have some milk in low fat cheeses and things like that in your diet. I do worry about people with Parkinson's getting too restrictive about how they're getting their calories, because people with Parkinson's more often have trouble with losing weight rather than gaining weight. And so we often want people to keep their weight where it is and not let it drift down. And a restrictive diet can make it hard to get enough calories in. I want to talk a little bit about exercise. And as you all know, exercise is particularly beneficial in Parkinson's disease, but it might also be beneficial for memory. In a pretty influential study that was done almost 15 years ago now, older adults who did not have any cognitive problems or Parkinson's disease were randomized to either exercising regularly or just doing stretching and toning that didn't involve any exercise. And the exercise here was sort of a brisk walk, about 20 or 30 minutes a day, 4 or 5 times a week. And what they measured was their memory and also the size of the hippocampus, the structure in the brain that's critical for memory. And sure enough, the people who exercised, instead of seeing their hippocampus shrink over time, their hippocampus actually got a little bit bigger over time, and their memory got a little bit better. So I think there's a lot of good evidence for aerobic exercise. The last thing I want to say is that at least in the Alzheimer's world, the main focus lately has been on combining all of these things, like exercise, eating a healthy diet, preventing vascular risk factors like high blood pressure and obesity and smoking, and also staying active mentally. So that's a little bit about how we might be able to prevent memory loss. I want to now talk about what to do about it when it does come on. And I'll talk a little bit first about Parkinson's disease and dementia, and where dementia is a term that I won't use a lot. I'll probably use memory loss more than the term, but just so that we're all on the same page. In the medical literature, when we say dementia, what we mean is someone who has cognitive impairment, usually involving memory, but other areas as well, that is bad enough that they're no longer able to do most of their day-to-day functions on their own. So someone with dementia is no longer, for instance, able to do their own cooking or manage their own medicines or do the finances. That's what we mean by dementia. Alzheimer's disease is the most common cause of dementia, but Parkinson's-related dementias, including from Parkinson's disease and Lewy body dementia, is the second most common cause of dementia or severe memory loss. There's a long history about this, as it turns out. James Parkinson, who first obviously wrote about and sort of discovered Parkinson's disease, he didn't think cognition was affected back in 1817, but he only followed a few people with it, and he didn't follow them very long. And even 150, 160 years ago, Charcot, a very famous revolutionary neurologist, thought that cognitive faculties were affected in Parkinson's disease. And we make a distinction in Parkinson's disease between people who have had Parkinson's disease for at least a year, and then they develop cognitive symptoms that are bad enough that it prevents them from doing their day-to-day functions. We call that Parkinson's disease dementia when that happens. When someone starts off with motor symptoms of Parkinson's and then after years develops severe cognitive problems. There's a second condition called dementia with Lewy bodies, and that's when the cognitive symptoms come on right away. In fact, the cognitive symptoms can come on before the motor symptoms, and sometimes they can happen even in the absence of any motor symptoms. But these two conditions, Parkinson's disease, dementia, and dementia with Lewy bodies, really are best thought of as being on the same spectrum. There's various sort of features that tell us that someone has one of these Lewy body dementias, including cognitive decline. And the cognitive symptoms tend to be particularly in executive function, that's sort of multitasking and be able to do a series of tasks in a row to get something done, and visual spatial function. In fact, lots of people with these Lewy body conditions have enough visual spatial function troubles that they sometimes go to the eye doctor thinking there must be something wrong with their glasses because they have a harder time finding things in a complex visual scene, like in a crowded refrigerator finding the ketchup or whatever. So cognitive symptoms are one of the core features. Fluctuations are another. That means people with these conditions tend to have times where they're quite a bit sharper and other times where they're more confused. They often have visual hallucinations, episodes of seeing animals or people that aren't there, especially in the dark or at nighttime. They have REM sleep behavior disorder. That's what we talked about, that acting out your dreams condition. And Parkinsonism. And Parkinsonism is the medical term for having slowness or stiffness of movement or tremor, the motor symptoms of Parkinson's disease. Risk factors for developing memory loss, specifically in Parkinson's disease. And age is definitely a risk factor. People who have early visual hallucinations, if that's part of their syndrome very early on, that is a risk factor for developing cognitive symptoms a little bit earlier, as is the REM behavior disorder, acting out your dreams. People whose motor symptoms start in there with walking troubles and stiffness of the neck and spine, that's a little bit of a worse prognosis than people who start with tremor in one side of the body or the other. And then often the cognitive symptoms start with visual spatial problems. So that's one of the areas that we're always looking for, is early visual spatial difficulties. There's a lot of ways to diagnose the cognitive symptoms in Parkinson's, but we often use a cognitive test called the MoCA, the Montreal Cognitive Assessment. And there's certain aspects of it that can help us as clinicians to sort out whether someone has more of an Alzheimer's pattern or a Lewy body pattern when on their cognitive testing. Now, one of the main goals, if I step back, I say I was talking about how Parkinson's is due to a misfolding protein, just like Alzheimer's is. One of the main goals we have is to try to see if we can visualize those proteins misfolding and building up in the brain. And in Alzheimer's, we actually are able to do that now, which is something that we couldn't do even 15 or 20 years ago. So Bill Klunk and his team at Pittsburgh developed a compound called Pittsburgh B, which is a PET tracer, something that's done in a PET scan to look for amyloid building up in the brain. Jackie, when I move my mouse around, can you see it moving?
Yeah, we can see that.
Perfect, excellent. So before Bill, the best kind of PET scan we had to look for Alzheimer's disease, for instance, was something called an FDG PET. And this looked at how active the brain was metabolically. And this is someone without Alzheimer's disease, and this is someone with Alzheimer's disease. And I think you can see that there's a little bit less reds back here. There's a little bit less metabolic activity here, but it's not sort of night and day. It's a little bit hard to detect, and it's not the most sensitive test. Whereas Pittsburgh B, someone without amyloid in their brain, their scan looks like this, and someone with amyloid, it looks like this. So suddenly it sort of lit up, and we could see amyloid building up in the brain. And in fact, we were able to show that it was specifically the plaques that was showing up on the amyloid PET scan. This is someone who passed away without any amyloid in their brain, and they had a negative amyloid PET scan. This is someone who passed away with a little bit of amyloid in their brain, and they had a partially positive amyloid PET scan. This is someone who passed away with a lot of amyloid in their brain, and their PET scan lit up. So we can definitely detect amyloid in the brain. In fact, we can also detect tau in the brain, but we can't yet detect synuclein. There are other ways to try to look for signs of it. One of them is called a dopamine transporter scan, or a DAT scan. And this is an example of that. But it's really just looking at how much dopamine there is in the midbrain, not specifically at synuclein. Now, there is a new kid on the block, but it doesn't involve the brain. It actually involves the skin. There's actually a way to do a skin biopsy to look for the alpha-synuclein in the nerves that go to the skin. And there's a punch biopsy that you can do. We typically do it on 3 spots: on the neck, on the forearm, and on the thigh. And we can look for the synuclein protein. And this test has now been shown to be very accurate, about 95 to 98% accurate in detecting synuclein, who has synuclein building up. And this was a test that was developed by Chris Gibbons and Roy Freeman at Beth Israel Deaconess, but is now a national and international tool that's being used all the time to confirm the diagnosis, particularly when we're unsure, when there are some features that are atypical or make us unsure as to what's exactly going on. So I talked a little bit about how there's sort of two different forms of cognitive impairment related to Parkinson's disease. There's people who develop Parkinson's disease first and then develop cognitive impairment. And there's people who develop cognitive impairment first and then develop motor symptoms either later or never. And I say that these two conditions are very similar, but one way that they're different is people who have dementia with Lewy bodies, who have the cognitive symptoms first, they often also have, in addition to Lewy bodies, Alzheimer's changes, amyloid building up in their brain. So one way to think about it is along a spectrum. If there's one end is Alzheimer's disease, where there's a lot of Alzheimer's proteins, amyloid and tau, and almost no synuclein, then there's dementia with Lewy bodies, where people have both synuclein and often have amyloid and tau. And then Parkinson's disease dementia, where it's mostly synuclein, but there's some risk of amyloid and tau. And then regular old Parkinson's disease without any cognitive symptoms, where there's very rarely any Alzheimer's changes. And here's an example of data to validate what I just said from Steve Gompertz at MGH. Steve did a amyloid PET scan study in people with Alzheimer's disease, and he showed that they had a lot of amyloid in their brain with Lewy body dementia, and they also had a lot of amyloid in their brain. But people with Parkinson's disease dementia had much less, similar to people with Parkinson's disease and healthy controls. In addition to looking at the proteins, one of the other things that we can do with PET scans is to look at the chemical neurotransmitters. So neurons, nerve cells in the brain, communicate by using neurotransmitters, chemical messages that tell each cell to fire. And one of the main ones that's important for memory, but also in general for cognitive function, is acetylcholine. And when acetylcholine is low or deficient, that can cause memory problems. And what we know is that acetylcholine is reduced in Alzheimer's disease, but it's even reduced more in people with Parkinson's disease, especially when they have cognitive impairment. Here are data showing the overall amount of reduction in acetylcholine in people with Alzheimer's disease, people who have Parkinson's disease without any cognitive impairment, and people with Parkinson's disease with cognitive impairment. So clearly there's a very large cholinergic deficit. Now, fortunately, there's things we can do to treat that. So just like we have medicines that can raise the amount of dopamine because of a dopamine deficiency, we have medicines that can raise the amount of acetylcholine because of a cholinergic deficiency. In fact, one of the very first trials that was done to see if the cognitive symptoms in Parkinson's disease could be treated was with a drug called ribostigmine. In this study, they compared ribostigmine to a placebo in people with Parkinson's disease and cognitive impairment. And sure enough, they showed that there was a marked improvement, that the people with Parkinson's disease and cognitive symptoms really got quite a bit better compared to the people who are on the placebo. In fact, ribostigmine used to be given as a pill, but the pill really causes blood levels to go very high and then drift down quickly over the course of the day. And then you take a and the levels go high and they drift down quickly. And this caused a lot of side effects, lots of nausea and other symptoms. So fortunately, ribostigmine came out as a pill form, as a patch form rather, as a little like Band-Aid that you put on every day. And that leads to much more even blood levels. So I think most people nowadays who are on ribostigmine or Exelon get it via the patch form so that the blood levels stay even. There's also pills, donepezil and galantamine, that have similar benefits. So that's a little bit about the cognitive symptoms. There are other non-motor symptoms that are common, particularly in Parkinson's, that are common in Parkinson's disease, including depression, anxiety, fatigue, sleep troubles, and sensory symptoms. But the one I really want to focus on next is depression. I'm sorry. I am going to talk about depression, but first I'm going to just talk about cognitive symptoms when someone doesn't have dementia. So people, even before they have dementia or separate from the dementia, people with Parkinson's disease can often have trouble with what we call working memory. And that's keeping information in your head for short periods of time, for like 20 or 30 seconds. The classic example of working memory is if someone tells you a telephone number and you're trying to keep it in your head and then write it down, for instance. And working memory can be affected in Parkinson's disease lots of different ways. So for instance, it can be directly related to the acetylcholine reduction. It can be due to injury to the parts of the brain that are important for working memory from Lewy bodies, but it also can be indirect. So people with Parkinson's disease who have depression have working memory troubles, and people in sleep disturbance, sleep deprivation can cause working memory troubles. Sometimes the medicines that people are on can affect their working memory. So one of the strategies to treat the cognitive symptoms when someone doesn't have dementia but just has working memory troubles, one is to minimize any medicines that might be making their cognition worse. And that's especially medicines that block acetylcholine. These are medicines like cogentin or Artane or Benadryl. Fortunately, we use these less and less these days. Another way to try to treat the cognitive symptoms when people just have working memory troubles is to improve their sleep, especially if they're having problems with daytime sleepiness. Treating their depression and anxiety can help. And also we can use the medicines that we've talked about, the cholinesterase inhibitors. These are medicines like donepezil, rivastigmine, and galantamine. So now I want to switch to depression. And this is one of my favorite slides to describe one of the challenges in recognizing depression in people with Parkinson's disease. It says how to recognize the moods of an Irish setter: happy, depressed, angry, pensive, excited, suicidal. And the point here is that people with Parkinson's disease have less facial expression and they have less expression in their voice. So I'll often ask people with Parkinson's disease, how are you doing with your mood? And they might say something like, I couldn't be doing better. My daughter got married last weekend. It was really one of the happiest days of my life. And I say, wow, I'm glad I asked. I would not have known that's what you were going to say based on, on how I thought you were doing. But other times I might ask someone how you're doing. They might say, really pretty badly. It's getting harder and harder. I really don't know how much more I can take of this. And I say, wow, I'm really glad I asked there as well, because I had no idea that your mood was low. So really, it's really critical that we always try to figure out how someone with Parkinson's disease is doing mood-wise by asking them, because we can often make judgments that are wrong because their facial expression isn't as obvious as it used to be before they had Parkinson's disease. And in fact, we know that Parkinson's disease is under-recognized, that about 40 to 50% of people with Parkinson's disease will have depression at some point in the course of their disease, that the depression is probably directly related to the Parkinson's disease itself. Because if we look at studies from other medical conditions that also cause a lot of disability, those conditions don't cause as much depression. And the depression in Parkinson's disease is tightly associated with a different chemical messenger in the brain called serotonin. So if there's really, we talked about how there are these neurotransmitters or chemical messengers in the brain. Three of the most important ones for people with Parkinson's disease are dopamine, and that's what causes motor symptoms and also maybe some of the working memory symptoms. Acetylcholine, which is really critical for memory, long-term memory, and that might be what causes some of those symptoms, and serotonin, and that might be what causes the depression. Because of this, a large clinical trial was done where they compared two different antidepressant medicines that can raise the amount of serotonin to a sugar pill in people with Parkinson's disease and depression. They compared a sugar pill or placebo to paroxetine or Paxil and venlafaxine, which is Effexor. And what you can see is both the venlafaxine and the paroxetine helped quite a bit in terms of reducing the depressive symptoms, much more than the placebo did. And either one of them seemed to work just about as well as the other. So really, it seems like pretty much any medicine that can take care of or replete or normalize the amount of serotonin can really help depression symptoms in people with Parkinson's disease. I want to talk just a little bit about anxiety as well, because anxiety is a real challenge in Parkinson's disease. About 30% of people with Parkinson's have anxiety, and we have little data on what actually can help. Now, we know from people who have anxiety in general who don't have Parkinson's disease that SSRIs, those serotonin drugs that we were talking about, can not only help depression, but they can help anxiety. There's another drug that we sometimes use called buspirone that was studied in a very small study, but there really has not been enough clear studies of how to treat anxiety in Parkinson's disease, unlike depression, which has been looked at a lot more fully. I'll talk just briefly about apathy as the last sort of cognitive or neuropsychiatric symptom. Apathy and its opposite, impulse control, can both be problems in Parkinson's disease. Impulse control is mainly a problem when people are on too much dopamine agonists. These are medicines like pramipexole and ropinirole. But the opposite, or apathy, is often seen in Parkinson's disease. That's sort of a lack of energy, a lack of get up and go, a lack of drive to start new activities. And we're really a little bit unsure about which of the chemical messengers, serotonin, acetylcholine, or maybe dopamine, cause apathy. And there's some trials going on now with therapies to try to improve that. So I want to leave a lot of time for questions. So I'm and you guys have all been asking good questions right along, but I just want to conclude by saying the hallmarks of Parkinson's disease are motor symptoms like rigidity or slowness of movement, bradykinesia, or tremor, but non-motor symptoms like depression and cognitive symptoms cause as much or more disability than the motor symptoms. But fortunately, there are symptomatic therapies that can help some of the cognitive symptoms and some of the mood symptoms, but we don't yet have a clear disease-modifying therapy. That's a medicine that prevents Parkinson's disease from getting worse over time. And I'll finish with James Parkinson, who now over 200 years ago said, there appears to be sufficient reason for hoping that some remedial process may before long be discovered by which at least the progress of the disease may be stopped. He was saying that because Parkinson's progresses slowly, we should be able to find something that can slow the progression of the disease. I think it's somewhat disheartening that it's taken us 200 years and we haven't yet developed something that we know slows the progression down, but it's also heartening that we're getting very close. I think there's very good evidence that exercise likely slows the progression of Parkinson's, and there are clinical trials going on that are working on preventing synuclein from spreading and building up in the brain that might also slow progression. And we're anxiously awaiting the results of those clinical trials in the next year or two. So I tried to leave us some time for questions, but you guys have been asking good questions right along. I'm going to stop sharing my screen. That's a really, really good and tough question. I think that it would be worth talking to a specialist, because it is possible. There are some clinical trials going on specifically in people who have REM behavior disorder to see if we can prevent the onset of Parkinson's in the very first place. But I think you would have to do it thoughtfully, because the person's absolutely right. There's no obvious intervention that we would do, although I think aerobic exercise, yeah, we would definitely promote exercise in that person. So I'm going to punt on that one. I would say that that's not a simple yes or no. I think that's a talk to a neurologist who knows what they're doing, so they can explore with you whether it's worth it or not. So the main side effects of ribostigmine and donepezil and galantamine, all three in that class, are nausea and diarrhea. About 20% of people will have side effects. So about 80% of people are able to tolerate it just fine. And I think when to start it is always a challenge, but I would say when the cognitive symptoms are causing you problems day to day, it's at least worth thinking about it and probably worth giving it a try. People with Parkinson's disease who have cognitive symptoms actually do better on those medicines than people with Alzheimer's disease. Even though those medicines were designed for people with Alzheimer's disease, the medicines pretty clearly can work quite a bit better in people with Parkinson's. It's my experience that about a third of the people who go on those medicines get significantly better, and they and their families say it definitely is helping quite a bit. About a third, it helps a little bit, but not dramatically. And about a third of people really don't seem to benefit at all, unfortunately. But because there's at least a third who get dramatically better and a third who get, at least moderately better, that's a lot higher than in Alzheimer's disease. And so I think it's definitely worth thinking about. Yes, I have a number of suggestions on this one. So the first is even though Parkinson's disease might be the cause of the cognitive symptoms and not Alzheimer's disease, I would strongly recommend making a connection to the Alzheimer's Association. Although it's called the Alzheimer's Association, it's really Alzheimer's and other associated dementias. It's just that's too long a title for them, so they don't call themselves that. But the Alzheimer's Association has a number of programs. They have a dementia care coordination program. They have support groups. They have a 24-hour helpline that you can call literally anytime, 24 hours a day, even on a holiday, and a clinician will answer and try to help you, especially if you're having a specific problem. So it's really a great resource. It's an excellent question. I do not know of any studies specifically like testing like the drugs to help cognitive symptoms in people with DBS. Two things about DBS. One is it used to have a little bit of a risk of making cognitive symptoms slightly worse, but that has largely disappeared as the surgery's gotten better and better. And people are starting to wonder about whether there's a way to do a DBS-like strategy to treat the cognitive symptoms. And there are clinical trials going on with that, but we don't know. We haven't cracked that nut yet. We don't know exactly whether DBS can be used to help the cognitive symptoms. And right now, typically DBS is only done in people who have minimal cognitive symptoms. I was afraid of really good questions like this. I'm going to leave now because I don't know the answer. So seriously though, what I would say is in people where we think that both Lewy bodies and amyloid are building up, it's unclear if just removing the amyloid would help or not. Right now, we don't know the answer to this question, and it needs to get studied, and it will get studied. But right now, what I would say is if we thought that most of the cognitive symptoms were due to amyloid, and there was only a little bit of signs of Lewy body disease, it might make sense to go on lecanemab. But if we think that both are going on, I don't think it would make sense because lecanemab is a challenging medicine. It has a lot of risks associated with it, and I don't think we know that it would help. Eventually, I think our whole field wants to get to a place where we would put someone on the right medicines depending on what proteins are building up. So maybe they would get more than one monoclonal antibody. Maybe they would get lecanemab and a monoclonal antibody to remove synuclein. That's where we're working towards, but we're not there yet. We're not there yet. They can be, usually the hallucinations are more visual than auditory, but it can be auditory, for sure, for sure. Sometimes white noise can help. Like if you have a white noise machine, so some background noise or something like that, it can help to suppress those sounds. Indirectly, we can't like give you a prescription for a gym or something like that, but there are physical therapy groups that are focused on exercise. For instance, there's one at BU where they do really, the physical therapists do lay out exercise programs, and BI physical therapists can also help with that, but we can't give you a prescription that allow you to go to a specific exercise class. It really has to be done by a physical therapist. Not yet. No, there is not. I think there are all those clinical factors that can help us to sort of assess someone's risk, but there isn't a blood test yet. There are ones that are being looked at in the Michael J. Fox study, but none of them have yet panned out. It's not for lack of trying. So, for instance, there's one NFL, which is also a TLA. I would point out another three-letter acronym, neurofilament light chain, has been looked at, as have others, but none of them have been shown with any usefulness that they can predict it. Absolutely. One of them is to stay mentally active, for instance, by attending Ask the Expert talks. And another one is exercise. That's what is really one of the focuses. Is I really want to the amount of benefit to the brain from these non-medicine interventions like exercise, mental activity, healthy diet. If that were available as a pill, it would be an amazing pill. We would pay a lot of money for it, and we would say it's really very, very successful. So I think we do have a lot of lifestyle interventions. One quick point is that at Beth Israel Deaconess, we were once considering doing an exercise trial for people with Parkinson's disease, and we had a hard time figuring out how we could do it because everyone was already doing such a good job. So many of the people with Parkinson's at Beth Israel are already exercising quite a bit. So honestly, some people are exercising maybe more than they need to. So I think a lot of people are already doing all the right things. I just remind you that it's likely working. It's likely working. Yeah. Yeah, so the best test for the Lewy bodies is that skin biopsy test that I mentioned, and that can be done, with your clinician. Again, we typically do it when there's some question about the diagnosis because it doesn't tell us how much Lewy bodies are there and whether they're going up or down, but it does give us a yes or no signal. In terms of amyloid PET scans are available, but only in very limited circumstances. Medicare only allows them to be done if someone's being tested to go on lecanemab, for instance. Um, so the risk of developing Alzheimer's disease, having a family history only raises your risk of Alzheimer's disease a little bit. By analogy, like I talked about how obesity, high blood pressure, high cholesterol, a sedentary lifestyle, any one or two of those is a bigger risk factor than the family history. So unless your family history is for very early onset, like developing the symptoms below the age of 60, for instance, having a parent who developed Alzheimer's disease in their 70s or 80s means your risk for developing Alzheimer's goes up only a little bit, not a lot. And I don't think that having another parent with Parkinson's disease changes that in any way. So I don't think that person's at extra risk because they have both Parkinson's and Alzheimer's in their family. Don't think so, not yet. Ultrasound is being studied for two different ways. There's a way of using ultrasound to create a lesion in the brain to cause a small brain injury that can conversely help things. So, for instance, there's ultrasound techniques to treat tremor, essential tremor, and they're similar to deep brain stimulation, only instead of stimulating the area, they actually cause a small lesion, a small brain injury in that little tiny area of the brain that they're aiming at. So it's not been shown to improve gait yet. It doesn't mean that it couldn't happen. There's a lot of research trying to figure out where in the brain we can stimulate to improve walking symptoms, especially. Yep. Sure. So I'll say them again. So the three drugs, I'll give you the generic names. You know how every drug has a generic and a brand name, but we try to use the generic names. The generic names are ribostigmine, donepezil, and galantamine. Those are the three. And their brand names, if you want them, are Exelon, Aricept, and Reminil. That's a common symptom of Parkinson's disease. It's probably not from the drugs, but it is from the Parkinson's disease. And excessive drooling is really, it's not because people with Parkinson's disease make more saliva. It's more that they have trouble sort of swallowing it, sort of staying on top of it. So a good tip is that like sucking candy, like a sugar-free sucking candy or something like that can help quite a bit if someone's having trouble with that. Yeah, that's very thoughtful of you. Certainly, there are what are called brain banks where the tissue is sort of looked at. It can help a little bit, but it's not a critical need. It's not like we're desperate to get it, like we're desperate to get kidneys from an organ transplant person or something. So I would say that that you can definitely let your doctor or family know if you're interested in making a brain donation after you pass away, but it is not sort of critically needed. So it's helpful, but not desperate is what I would say. That's a really good question. The short answer is yes, they do. Driving requires a lot of visual spatial function, and people with Parkinson's have to be particularly careful around driving because there's real driving safety issues that can occur. And that's definitely worth talking with your clinician about if you're starting to have some concerns or your family is starting to have some concerns around driving. It doesn't mean that you need to stop driving right away. There's tests that we can do to figure out how risky it is for you and ways that we can lower the risk. For instance, driving in daytime hours and when conditions are good. But for sure, visual spatial function is critical for driving. Um, a lot. A lot is the answer. You know, we're very interested in this. So one of the interesting things about Parkinson's disease when it affects people is it causes people to draw things smaller. So, for instance, their handwriting, although it often just becomes messy, it often becomes smaller. And one of the questions that we asked in a research study a number of years ago was, we have people with Parkinson's disease, if we draw a box and we have them copy the box, they tend to make the box smaller. And then if they copy that box, they make it smaller still. And if they copy that box, they make it smaller still. And Alvaro Pascual-Leon, a colleague of mine, called it the Russian doll sign, because it's like those Russian dolls that get nested in each one. And it's an interesting sort of aspect of the disease that by definition, if someone copies a 4-inch square and they make it 3 inches, and then they copy a 3-inch square and they make it 2 inches, and they copy a 2-inch square and they make it 1 inch, clearly people can draw a 4-inch square. They, because if they copied a 5-inch square, it would have been 4 inches. So why is it that it comes out smaller all the time? And it looks like it's because the initial movement is too small, and then people have a hard time sort of correcting for that. So there's two parts to Parkinson's in that sense. There's the movement is a little too small, and it's then hard to correct for that and make a second movement. And so we have learned quite a bit from studies of handwriting and other sort of drawing aspects of Parkinson's.